Nidhi Biani, student of MBA, Hospital and Healthcare Management Program from Symbiosis Institute of Health Sciences, on behalf of Symbiosis International University, welcomes each one of you for the first session of today on Health Information Technology. Before we move ahead, we solicit your cooperation, and for convenience, there are a few announcements. For availing Maharashtra Medical Council credit, MBBS doctors should register on both the days. For availing Maharashtra Nursing Council credit, nurses should register on both the days at Central Library. We would do much better if we receive your valuable feedbacks. To consider the same, a link containing feedback form is already shared by an email to all the esteemed delegates and all the registered candidates. After receiving the receipt of feedback form, e-certificates will be sent via email. It supports the management of information across the computerized system and secures the information between consumers, providers, and payers. To know more about such advancement in healthcare, today we have with us our very own Dr. Lalit Katpalia, Director, Symbiosis Institute of Computer Studies and Research. May I now request Dr. Lalit sir to accompany our speakers onto the dais. Dr. Anupam Saraf, Future Designer and Growth Strategist. Mr. Milind Kaur, SVP Analytics, Oham Healthcare Solutions Private Limited. Mr. Pankaj Kakkar, Director, Data Mining. Mr. Pranay Goyal, Associate Professor, Indian Institute of Science, Education and Research. Mrs. Linda Robertson, CEO, Paper Tracer Software System US. Mr. Pankaj Kanchankar, Commercial Director, Satwix Informatics. Dr. Lalit Katpalia is an IT professional with 27 years of experience, both in India and abroad, in software development, education training program management over varied platforms. He is a recipient of prestigious IBM Faculty Award 2012. Dr. Lalit's PhD is in the area of developing a system dynamic stimulation model for Indian IT industry. Sir is also on board on system dynamic stimulation model for Indian IT industry. I request you, sir, to take the session forward.
Morning, friends. Can I request, how many of you are the students of SICSR, SCIT? Can you raise your hands, please? Can you all come forward? I know you are used to sitting at the back benches. Can you all come forward, please? The people who come forward will get a first class in their final semester, I assure you that. And I hope the university is not hearing that. That's not subject to clearance, but anyway. Can you guys come forward? I want to see all your beautiful faces. I'm used to seeing you. I want you to mingle with the audience. And also, there are some 5 students who are supposed to be live tweeting about this event. If you could meet Tejaswini and Meenal on the passwords and stuff like that. Okay, fast guys, if you want to lose weight, you got to run fast, and it's a healthcare track on technology. Technology can't reduce weight, healthcare can. Fast guys, I thought you all were athletes. Yeah, thank you. First of all, a very good morning to you, and I hope all of you are healthy. Are all of you healthy or no? If you're not, I have a surprise for you. How many people suffer from blood pressure here? Please raise your hands. Wow. We have a GPS which is tracking your position. I'll talk to you about that. How many of you suffer from diabetes? Please raise your hands so that the GPS can locate you. Yeah. From acidity? Oh, okay, we got lesser folks here. Okay, a small request to you, please do not touch any sensor equipment below your seats. I assure you that at the end of this track, you will be cured of blood pressure, diabetes, and acidity. We have a sensor based on Internet of Things. Unfortunately, the speakers in this conference are all healthy folks, unlike some of us. So that's why they're over here on the dais and they don't have these sensors. So these Internet of Things sensors which we have at the bottom of your seats will ensure that you have a very big holistic experience and healing. How that works, that's covered in the Health Times, which is a publication book which we have launched. So that's healthcare technology track for you. Welcome aboard the healthcare technology track. We have the gods of healthcare and technology on this stage. We've got Dr. Anupam Saraf, Milind Paul, Linda, who's the CEO of Paper Tracer. We've got two Pankajas. One is an open source guy, one is a other technology guy. Pankaj Kanchankar, who will talk about open source technologies and stuff like that. We've got Pankaj Kakkar, who's built in some of the sensors which is below your seats. And I can assure you that you'll get healed. If that does not work, then we'll check. You can come back to us. Pankaj's number, I'll share it with you. And we also have Dr. Pranay Goyal. He's from Indian Institute of Science, Education and Research. So one quick tip before we start. I want all of you to smile and give a big hand to the speakers. They usually charge each of these speakers charge $1 million, but they are my friends, so they said, Lalit, we'll waive you of those charges. I see Dr. Alka nodding. She's trying to say that, Lalit, you can debit it to the students. Sorry, we can't. Thank you very much. I'll ask Dr. Anupam to talk about that.
Very good morning to all of you. I think we have an exciting morning with 5 very distinguished speakers here. And I thought before they start off, I wanted to raise the ceiling and give a little bit of quick overview on this track. So firstly, I think when you talk about India's status in the world in terms of healthcare, we are way back 143 in 188 nations. And I think that's somewhat an indicator in terms of where we stand in terms of using information well or badly in terms of managing health. And this is despite the fact that since 1960, the total longevity, the life expectancy in the country has risen from somewhere around 42 years to 68 years. And when we look at the various diseases which kill people in India, I think we see that coronary heart diseases are at the top. Then we have lung diseases and so on and so forth. So if you were to look at some of these, India is even #1 in the world in terms of deaths due to lung diseases. So all the reds that you see there are all the alarming causes for death in India. And obviously, we don't seem to have a mechanism whereby our healthcare system is paying any attention to these key causes which exist in India. Given that there are all kinds of reasons why people can fall ill, be in bad health, or disease can spread in a city or across the country, it's important that you have all kinds of information systems which play a role. This is something that I had done in 2009 when H1N1 spread. I happened to be the CIO of Pune City at that time, and we sourced information from the net in order to track the spread of H1N1 in Pune. And we actually found that there was a locus of spread along in the Kothurud area, along Karve Road and Null Stop and what have you. And if we had actually managed to quarantine that area at that point of time, there would have been a lot of difference. Variety of reasons why we actually didn't do that. But subsequently, the tools that were available from Google in order to track flu came under disrepute because it was recognized that this big data which they were using of people searching the web with the term flu had some kind of limitations in terms of being accurate to predict the spread of flu across the world. But this data, when you plot it, it's interesting that you find that it does show sharp seasonal peaks in the northern hemisphere at the same time and in the southern hemisphere at a different time. So there is still some value in terms of looking at this kind of data. However, data scientists have continued to use this kind of tools to be able to track what's happening across the world, what's happening across a country. And here you have India, where somebody has actually developed a tool to track the news items appearing across the country relating to particular outbreaks of flu, in this case H1N1. So you can see here there is one in actually April 2017 on H1N1 breaking out from Pune. You can verify whether this is accurate or inaccurate. Another one which actually is tracking a whole lot of outbreaks and alerts for different kind of vector-borne diseases across the world. And at the bottom, you can actually see the seasonal peaks for over time in different countries. In the United States, if you compare it, there is a far greater focus, and you can actually see that there are a number of organizations from CDC to Google and Athena which are tracking different kinds of flu outbreaks in different states across the United States. However, when it comes to tracking these, we somehow tend to ignore the fact that when you contract disease, you are actually having a susceptible population which moves on to becoming exposed and then get infected and then finally recovers. And there is a dynamic which plays out, which can be modeled, and you can actually find out where should we intervene in this process in order to be effective. And if we actually had more such models, which we created for every kind of disease spread, we will be able to make informed decisions in terms of how to intervene and where to intervene. In the United States, you have a detailed health information system which goes down to the county level, which allows you to focus on the county and find out what is driving health in each of these counties. So if you zoom in into one of the counties, in this case I've gone into Middle Essex in Massachusetts, and if you look at the health outcomes that they talk of, they are focusing on the length of life and the quality of life. And on the other hand, they are focusing and allowing us to look at what are the health factors, the health behaviors, the clinical care, the social and economic factors, and physical environment, which affects the health outcomes. So it's possible for you to actually look at how does this compare vis-a-vis the rest of the country and any other county that you wish to, and actually work towards ensuring the health of the county. Here are maps which the CDC Division for Health, Disease and Stroke Prevention is actually putting out in terms of all the counties and looking at what is the population under 65 without insurance, those who are without a school diploma, what is the unemployment rate, what is the population which is living below poverty, because all of these factors are going to affect the health of this community. Here is another map which actually talks about how many of these people are alcoholics. So you have the possibility of actually presenting what is going to affect health in a variety of ways. And I think it's extremely important to recognize this, because this is going to be the basis of decision-making and policy-making, more importantly, in order to be able to drive what happens in the country. In India, we have a number of initiatives at the government level, and one of the most interesting ones is data.gov.in. It's in its infancy. However, there's a lot to be desired in terms of what is the information which comes out as open data in the health sector. And I hope that some of my panelists will at least touch upon and talk about what kind of data they would like to see coming out as open data in the health sector in order to be able to deal with the health scenario across the country more effectively. India has also been experimenting with health management information system in association with the World Health Organization right since the 1990s. However, there is a lot left to be desired in this area. We have a number of states, and you can see they have different districts. At each district level, at the very least, we need to have something similar to what I showed to you in terms of what the American counties have in order to be able to tell what is the health outcome and what is the health scenario that exists over there. So I hope that with this, I probably will be complementing what my fellow panelists are going to talk about. And they have a rich set of tools and information systems that they're going to talk about. I hope that they will address some of the issues that create a gap between what policies exist in the health sector, what information is available for the health sector, and what needs to be made available. So with this short introduction, I would like to call Lalit to introduce the first speaker in the panel. Thank you.
My apologies to Dr. Anupam Saraf. I should have introduced him, and I'm sorry because to many of my students, he's one of our star faculty, which we call as an Amitabh Bachchan of our faculty. Dr. Anupam Saraf is a respected innovator, and he's been an advisor in governance, informatics, and strategy planning. Dr. Anupam Saraf has obtained a PhD from the Research Groningen in informatics. He was the first Chief Information Officer of Pune City, and for many of you who are from outside Pune and outside India, Pune was the first city to have a Chief Information Officer, and Dr. Anupam happened to be the Chief Information Officer. He has implemented revolutionary ideas on crowdsourced governance. He's been highly influential and effective in promoting the use of social networking tools in modern e-governance. And he was an advisor to Mr. Manohar Parrikar, the current Chief Minister and also the former Chief Minister of Goa. And that's where he contributed to creating a digital society and introducing governance reforms. Dr. Saraf serves as an independent director on the boards of public and private sector companies and NGOs. One important thing about Dr. Anupam Saraf, which is not on his bio, he was the guy who made my PhD possible, and thanks to him, he's my guru, so a lot of respect for my guru. Thank you very much. So we are on track. As IT guys, we are all part of people who are tracking projects, deliveries, software which is being delivered for healthcare and lots of stuff. And a couple of my friends here from Infosys are also here, and they all know that how cautious we are on delivering a program or a project. So the good news is that we are on track. We are absolutely on track. And the next speaker we have is Mr. Milind Pol, who is Vice President Analytics, OHM Healthcare. Milind is a graduate from IIT Mumbai. He specializes in project management, program management, business operations, strategic planning, and execution. There are lots of other stuff. I'll cut it down for time constraints. He has led and developed one of the smartest and brilliant communication campaign, which brings an edge to software delivery as a differentiator. He's developed complete care, business intelligence, health analytics, and big data predictive analytics products for his company. He's well-versed in offshore software delivery, operations management, and engagement management. Milind is an effective analyst, problem solver, and communicator, able to forge solid relationships with upper-level executive leaders and build consensus across multiple organizations. The reason why Milind is here is that he's going to be talking on his experiences on developing a product and what he has done in the area of healthcare using technology. The topic on which Milind will be talking about is IT as an enabler for patient care and safety. Please give Milind a big hand. Thank you very much.
Good morning. I'll just continue from what Lalit talked about me. Probably he is a good friend of mine, so he did a lot of good stuff. But last about 10 years, I have been working on the healthcare IT. And coming from banking, finance, retail, other sectors, what I realized was healthcare was a completely different beast. The way healthcare adopts to technology is completely different. If you really look at it, I mean, I did my rent agreement registration few days back. It was a very simple, automated process. All I needed was the Aadhaar card number, and authentication happened on my fingertips. Everything is digitized, very simple, yet very effective. We see, I mean, Google Maps, there are a lot of technology that we use on an everyday basis. Can the same technology be used in healthcare? Can we really get the same successes coming into the healthcare? The answer is yes. Over the next about 15, 17 minutes that Lalit has given me, I would be talking about how the world is changing around us and how we are going to be seeing IT of tomorrow. Let's, let's talk about the patient safety for a second. If you really look at it, there is no data for India, actually, but about 440,000 avoidable deaths happen in US alone. That's like 3 Boeing 747s crashing each day. And none of these things come on the newspaper. Forget about the front page. 10 times more are the incidents. If you really look at it, Harvard actually ran a study. It's not the mistakes done by the incompetent people, but the mistakes done by really good people trying to follow the right processes. If you really get onto the details, it's the variability of the care that is what results into these errors. What we really need to be looking at is the variability. Drive to zero targeted tools. When you design for zero, you surface different ideas and approaches. It's about purposefully aiming for a higher level of performance. Let it be false. You want to look at false differently. Let it be the communication that happens between the care providers. Let it be hand hygiene, very basic things. If you could really look at these basic things, you would be able to improve the quality of care, reduce the safety incidents. What we need today is a complete digital platform, which is patient-centric, clinician-led, which is guided by evidence-based guidelines, which follows best practices of the industry, which has got integrated applications, and which is driven by transformation underneath. In last decade, there's been a lot of work that is happening in the mother and child health. We are seeing a lot of improvements, even in the Indian numbers. If we could look at how we could take that forward in improving, how can we use IT into that? Let me quickly show you a video where we would look at how IT can actually enable. This is an EMR where I'm putting in the admission order for the patient. I select what the patient is getting admitted for. As soon as the patient comes to the front office is admitting this patient, allocating ward, putting in the insurance information, bed allocation is happening. This is the OPK sheet. You could review the past record, all the last 9 months of the data. You could have data entry in form of voice inputs, and it's been very, very accurate. So here is the examination being done, the IP assessment, the general examination. Notice, we have purposefully removed typing from here. Everything is either touch or the audio input. If we actually need to get IT closer, as close as possible to the end user. And that is what is being, this is the partograph of the patient. You see the graph and you do the entries on the same screen. So the idea here is to capture information as effectively, as efficiently, and then being able to provide that same information at the point of care where it really, really makes sense. Once the data is digitized, we could also use that for further analysis. So this is the prenatal chart. Discharge assessment, the discharge process is extremely simply. In normal hospitals, it takes at least 2 hours, 3 hours to create the discharge summary. Here, everything is digitized, all the data is available, all you need is a discharge advice. And then signing on it, this is the discharge summary. This is the dashboard, the data. Once we capture the data, I could look at the performance of my hospital, how is it being done. And then, most importantly, I could also look at the actionable patients. These are the patients who are currently in my hospital who probably need better care. When it comes to chronic cases, the thing is little different. From clinician-led in the hospital setting, we need to move towards patient-centric, patient-led. Can I have choice of my hospitals? Can I have choice of my clinics? Can I have choice of my labs? Can I look at different labs, different pharmacies around my house, compare them for timeliness, the accuracy, whatever? Can I look at patients like me? For example, I mean, if somebody is hypertensive, diabetes with multiple comorbidities, and he has already visited multiple clinicians, can I still look at patients like me, maybe from Australia, maybe from United States, wherever? And can I create a cohort group where we are able to share lots of very simple things? It is proven, and there is a lot of study which is still going on, is behavior nudging is the best way of treating most of the chronic diseases. Let's look at some video on the diabetes management. Here, for the diabetes, this is the first assessment that the clinician has been doing, looking at the complaints, putting in the history of present illness, marking all the markings are always touch. We don't want and this is an iPad-based application which clinician can carry anywhere he wants. So he could order the different investigations, give the advice. As soon as the report comes, the patient will be marked with diabetes up there, it's red. So whenever I see this patient, I know different comorbid conditions of this particular patient. And then, let's say this is a diabetes treatment plan which will be driven from the different comorbid conditions. We will do risk assessment. You would look at the FINRISK score being calculated, auto-calculated as the entry is being made. The guidelines will be used, evidence-based guidelines, best practices to help or assist the clinician make the best decision. And this is where the prescription note could be generated. Quickly look at the patient app. So this is the patient app where patients will be able to enter his or her own vitals. The beauty is this will be integrated with the EMR of my choice, with the clinician of my choice. And as I enter the data here on my handheld device, it goes into my EMR. I can integrate this with Fitbits of this world. This is the graph that I could see. I could look at the laboratory investigations pending integrated with the lab of my choice. These are the medications. I could get alerted for the medications. And then this is the appointments that I have. I can do tele-health call right from here. So I'm calling the clinician. Clinician is looking at my EMR from his system, putting in the advice, the medications, he signs it. As soon as the note is signed, I get to see the prescription on my handheld device. The same prescription can go to my pharmacy of the choice. So it's basically building in, putting in the complete system together so as we could get the best out of it. Let's take a few minutes to look at the possible safety areas. VTE, this is the single most preventable cause of death in hospital. About 60% of deaths happen because of VTE. And to save from VTE, there are very simple preventive measures that one needs to be taking. So on the video, you see down there the VTE risk assessment reminder popping up. This pops up 48 hours after the admission, and I need to do the risk management of the patient. Based on that, I need to provide the treatment of the patient. The orders will go to the right departments, the patient care is taken out, and the reminder is resolved from here. This is the quality dashboard, how my hospital is doing on the VT, and most important, this is the actionable. These are the current inpatients for whom, even after giving reminders, the action is not taken from my clinical team. VAP, 46% of the hospital mortality of the ventilated patients is also linked with VAP. So how could we do that? As soon as I put in ventilator for a particular patient, I get a VAP reminder. I need to do the risk assessment. I can even put in the orders right from here. So basically preventive and then prescriptive measures is what I would need to be taking at different intervals. And I don't need to remember all these things. There is system, there is IT, which is there to guide us. This is the quality of VAP for a particular hospital. And then in actionable, all the actions that people still fail to do. We are humans, right? We still keep making mistakes and assumptions. Next one, please. The medical administration. Medical administration is the biggest area and the simplest area where we could have a lot of improvement. If you look at the ordering, you need to make sure that different order checks happen. You check for drug-to-drug interactions. You need to check for drug-to-allergy interactions. I should not be giving same class drugs. I should not be giving overdosages for the drug. This is the kind of order check that the system will remind me. I can still override, but then if I override, I get audited. And you can have the quality teams of hospitals look at the data and then capture the reasons for it. This is the medicine administration in the wards, hospitals. What really happens is you have barcodes. And first, while giving the medicine, the nurse will need to scan barcode of the patient, need to scan barcode of the medication. She will be scanning barcode of herself, that is the nurse. So it's the right patient, right medication given by the right person at the right time, and then the route is captured there. And this is what we did it in a manual way on the screen. But if you are doing it on manual way, I can always have audits and I can always have reasons for continuous improvement. When I capture all these things, I can have continuous improvements in my hospitals. Readmission and prediction. If you really look at it, readmissions can be linked with about 20% of heart attack patients, 25% of heart failure patients, and 18% of pneumonia patients. Can we do something about the readmissions? This is where we are working on the AIs and the machine learning of this world. So at the time of admission itself, looking at all the data available of the patient, which is literally impossible for a human being to look at all the reports, everything. So machine can look at it, and it can then have sniffer algorithms to predict and prescribe the risk scores. The high-risk patients, I would take them through customized intervention protocols to reduce the risks of readmission as they are in my hospital. At the time of discharge preparation, one more time, I do the same exercise. High-risk patients coming out then, I could actually delay their discharge for a couple of days in the, to get the better quality of care. Even after discharge, I could monitor them more effectively. I can give them wearable devices. I can make sure that they come for the OP. This is a video, the technology of data mining and the NLP as it is being worked out. SNOMED is a dictionary that is actually available for us Indians. Indian government is paying a lot of money to make it freely available to everyone that wants to use it. And this dictionary can be used to effectively mine the data out of notes